Yeah, that's fine. Right, right, sure.
I don't know what I'm going to say. You never know until I do it.
Okay, well, I think we're going to get started. Good afternoon, everyone. My name is Amelia Aria, and I'm an associate professor in the Department of Behavioral and Community Health at the University of Maryland School of Public Health here at College Park. And it is my great pleasure to welcome you to Widening the Lens on the Opioid Crisis. I hope you've enjoyed your day here at Public Health Research at Maryland Day. What we're going to do is we're going to make this very interactive, so you're being encouraged to come up so that you can ask questions of the panel. I am going to go through a few introductory slides with my co-moderator, Dr. Brandt from the University of Maryland in Baltimore. And then from there, it'll be all interactive discussion. So you'll have a chance to ask questions and hopefully get a lot out of this. So today's panel is a unique blend of people with different disciplines who are attacking this problem from different angles. So widening the lens actually has two meanings. One, we want to widen the lens because it is more than just an opioid crisis. It's really an addiction crisis, as you will know by the end of today, if you don't know that already. And the other part of widening the lens is the age that it affects. So the age groups that it affects are all the way from adolescence all the way through older adulthood. So we hope to enrich the discussion by including people who are both researchers, clinicians, and community-based providers. So we're going to introduce them a little bit later. So the purpose of today is really to provide a very brief update on the opioid crisis, but really the whole point of today is to stimulate dialogue and encourage networking among people who have similar interests. So I hope that you'll have a chance to network amongst yourselves and get to meet the panelists at the end. So what we're going to do is after the introductory comments, we're going to ask the panelists a question about what is the most important aspect of the problem from their lens. And then we're going to ask you for your questions, and we're going to flip it back and do moderated discussions with the panel about their current strategies and their future challenges. And then we'll take questions at the end as well. But to put this in perspective, I am an epidemiologist and have been doing research on drug use and addiction for about 23 years. And we have been, at my center at the School of Public Health, we have been looking across the spectrum of substance use behaviors, including what can we do to limit opportunity exposure to different substances and underage drinking, all the way through what can you do when people need treatment. So I think it's important to see this problem as something that has roots in adolescence and young adulthood, but affects all kinds of people and has different levels of severity depending on what population you're studying. At the prevention level, there are so many things that we can do in terms of limiting availability, changing our policies, and also providing individual level assessments to people who might be at risk. And this is one area where the research really needs to be translated to make sure that in practical and sensible ways so that people who are at risk for these problems get the help that they need. But turning back to the problem at hand, the opioid crisis has really gripped this country because the overdose death rate has really skyrocketed. And when something like this happens, obviously it's going to get the attention of policymakers and communities all over the country. In 2016, 2/3 of all drug overdose deaths in the US involved an opioid, and in Maryland it was even higher, with 89% resulting from an opioid. And as you can see, that curve is just skyrocketing. It doesn't look like we're making progress, but I know that so many communities across the country are trying so many different things to make sure that we do something about this epidemic. We know that synthetic opioids are just one part of the problem, but the sharpest increases in drug overdose deaths has been related to fentanyl and fentanyl analogs. Like I said before, this is a problem that affects all age groups, and as you can see, youth and young adults are disproportionately affected by using non-medical prescription opioids, but there isn't one age group that doesn't have issues. And when you look at the absolute numbers of people, because there are so many people in the older age groups, the absolute numbers are a lot higher in that group from age 26 and older. And this is opioid use disorder. I'm going to go through these fairly quickly. They'll be available if you would like them. But one of the major themes of today, from my perspective, widening the lens on the opioid crisis, is that this is not a single drug problem. The number of drugs involved in overdose deaths are numerous, and almost half of these drug overdoses had another drug on board. So, and I think Eric Wish has other data showing that even more drugs are involved than we think. Again, the overdoses are involving other drugs, and in particular, the benzodiazepines are involved in about 30% of drug overdoses, alcohol in about 20%. So we are not just seeing a person die of an opioid overdose, but really multiple drugs. From a prevention standpoint, there's lots of data to suggest that people who non-medically use prescription opioids and transition to heroin have a history of other drug involvement. And in particular, a lot of attention has been focused on the predictive value of using marijuana in adolescence. And people who use marijuana are much more likely to transition to other drugs. And this is a recent study of national data showing that marijuana users are much more likely to start using prescription opioids and also develop opioid use disorder, two separate studies of national data. Again, individuals who use opioids have a long history of other drug use. Close to 3/4 of individuals in drug treatment have another problem besides their opioid problem when they show up into drug treatment. And on the horizon is increasing cocaine overdose deaths. So there were some recent studies showing that cocaine overdose deaths are increasing, especially in the African American community. And so I think as a nation and as public health professionals, we can't just be chasing after the drug. We have to be doing something at a more systemic level, at the root of this problem, which is trying to identify people who are at risk for all kinds of drug problems. So it's really, let's focus on the people at risk, not necessarily just the drug. So from a public health perspective, the overdose crisis represents sort of a tip of the iceberg for me. There's people who are suffering with drug disorders underneath the people who are overdosing. Plus, there's a bunch of people who are at risk for transitioning into more severe forms of use and addiction. So I'm going to let my colleague, Nicole Brandt, introduce herself and talk about the crisis in older adults.
Hey, well, good afternoon, everybody, and thank you for showing up for this great program. And I really want to thank Amelia and the team here at College Park for the invitation. My background's a little bit different. I'm not a public health researcher. I'm actually a practicing pharmacist. And I've spent my 20-plus careers actually focusing on the needs of older adults, oftentimes a population that isn't thought about in public media when we think about the opioid crisis. I work still as a practitioner. I work in an interprofessional clinic serving those at greatest risk. As we say in healthcare, we look at the 5% spending 95% of healthcare dollars. So I care for patients with multiple chronic conditions, taking multiple medications that are primarily residing in the community, lower health literacy, and less awareness to kind of sometimes all the issues going on. But what I definitely find as I left the inner city of Baltimore, is there's so much attention and education that needs to be done for the family, for the caregivers, for our patients. And what I'm seeing as a practitioner is a little bit alarming as we deal with this crisis at hand, and it's the access issue. It's access to medications, it's access to services. So I'm really excited by the panelists that we have here today. And on behalf of the students I educate, I'm happy to see so many students in the room that can further this dialogue upon vulnerable patient populations, because not only are we going to be talking about the elderly, but we're talking about patients with comorbid diseases like mental illness. So when we talk about addiction disorders and those mental illness and services they need. So I want to spend a moment sharing with you statistics, again, a population that doesn't always get reported out there. And what we see is older adults. Those 65 plus may be getting ignored. And when we're dealing with chronic comorbidities, chronic pain is one of those issues we're often facing. We're dealing with conditions like long-standing osteoarthritis. Literally, before I came here, I was dealing what I deal with in a lot of my world is prior authorization, advocating for our patients to get access to medication. And the daughter encapsulated it best. She said, Dr. Brandt, she said, Mom has dementia, right? Cognitive disorders become more common as we get older. She can't really advocate for herself. She can't express pain very well. And I don't want to put her on an opiate because we know it's going to increase her fall risk, right? We talk about sentinel events, we talk about hazards. And she goes, it also makes her more confused. So when we talk about med safety, we look at opiates and we know that they're one of the high-risk medications that lead to preventable adverse drug events. And there's a lot of literature out there. And she said, so why can't I get that lidocaine patch that's no longer covered by the insurance because it doesn't meet a particular indication for use? So there's a lot of advocacy that needs to be done on alternatives to opiates in terms of managing pain, because when we're dealing with chronic pain, it's not like we turn a switch on and off. They've been dealing with it for a long time, especially conditions like spinal stenosis, when patients have lower back pain and chronic pain. So I think there's a lot of work to be done. So again, I advocate for our older adults and their families here. And we know that when we look at the growth of opioid use, one of the greatest groups that are using them is our Medicare population. And when we traditionally think of Medicare, we think of 65 plus, but we have to remember we have individuals with end-stage renal disease. We have individuals with other types of disabilities. So we have to make sure we're advocating not just for an older cohort, but those at vulnerable population. And what we're seeing is that 30%, currently 12 million, and we saw some additional statistics, are receiving an opiate prescription. So this has truly become a bullseye for our Medicare Part D plans and our Medicare Advantage plans. And every year, just about this time, it's an exciting time. All the plans that cover prescription drugs, they put out what's called a call letter. And out of the 300-page document, there was at least 10% of them on opioid use, and all the different initiatives that we're taking to try to curtail opioid use, from quantity limits to prior authorizations to indications for use, off-label prescribing and such. So we know that we're trying to do different tactics to address the use of a product, but I think Amelia stated it well. It's not just the use of a product, but it's the supportive services that we need to accompany the medications that we're using. And from 1995 to 2010, we saw this 14-fold increase in opioid use in, again, the Medicare population, and 9-fold increase, so staggering statistics. And what we often see, too, in older patients is not just the use of the opioids, but the concomitant use. So again, in the world I reside as a practitioner, we have this very predominant warning that's put out by the Food and Drug Administration. It's called the black box warning. And there was a black box warning that was placed on the concomitant use of benzodiazepines, things like Ativan or lorazepam and diazepam or Valium, plus the use of opioids. So we're seeing that concomitant use. And over a quarter of our patients are using those sedative hypnotics on a regular basis, as well as taking those opioids. And I think, again, when we think about public safety, it increases not only our risk for falling and confusion, it increases our risk for death. And so it's, again, one of those public health concerns that we need to pay attention to. And so we look at multiple things. We look at cognitive decline. Many of our patients are facing cognitive issues, falls and traumatic brain injury, dependence, and overdose. And as I mentioned, some patient populations are even greater risk. And the number of adults aged 50 years with a substance use disorder will double just in the next couple of years. So a lot more work needs to be done to support the services besides just supporting the medications. So how did we get here and where do we go now? Well, I think, again, we have a very distinguished panel. And I'll say in my 20 years plus as a practitioner, there's been multiple guidelines that have come out. I've worked with agencies like the American Geriatric Society, and I think we're all facing the conundrum of where we look at risk and harms and benefits of all medications. And there's many medications out there, opioids and some of the readily available over-the-counter, what we call non-steroidal anti-inflammatory drugs like naproxen. And every medication has potential for harm, and at the same token, we hope the benefits outweigh the harm, but it's been very much a conundrum on how we address pain. So we've gotten here because we're a society that likes to go to a pill for every ill, and we need to do more to support addressing that kind of crutch. I've heard it from patients. It's a crutch. It doesn't alleviate or get rid of the pain completely, but it's a crutch to help me manage and function more. But we can't just move the pendulum all the way to the other side and say we can't use them anymore. I think we need to put systems and programs in place that, again, can support our older, vulnerable patient population. And so when we were trained, the fifth vital sign being pain, and pain is still a vital sign, but I think we need to do more on how we assess it, how we properly educate when we talk about the benefits and harms of the medications that we're using, and really listen to our patients to provide alternatives and really focus them on their needs of where they're at, especially when we're dealing with multimorbidities, substance use disorders, dependence, and other chronic conditions. So I'd like to take a moment to introduce some of our panelists. So Kim Burton has been a colleague and friend through the years. I'll tell you a little bit about Kim. Kim is the Director of Older Adult Programs for the Mental Health Association of Services and Access to Care for Older Adults with Mental Health and Substance Use Disorders in community and long-term care settings. She's been working in the field of geriatric behavioral health for more than 20 years, and she specializes in professional education regarding aging and behavioral health, including dementia and issues of caregiving. Kim received her BA in Human Services in 1988 from the George Washington University and completed the Geriatric Mental Health Specialist Certificate Program at the University of Washington in 1992. Kim, do you want to come join us up at the big kids table up here, right? And right next to Kim will be Kathy Cameron. And again, Kathy I've known through the years and very happy that my colleagues in aging were able to join us. Kathy has been in this field for over 25 years with experience as a pharmacist as well, a researcher and program director focusing on falls prevention, geriatric pharmacotherapy, mental health, long-term services, and supports and caregiving. Currently, Kathy is a senior director for Center for Healthy Aging at the National Council on Aging, NCOA, where she oversees the Administration on Aging, funded National Falls Prevention Resource Center, and National Chronic Disease Self-Management Education Resource Center. The focus of her work is to support the expansion and sustainability of evidence-based health promotion and disease prevention programs in the community and online through collaboration with national, state, and community partners. Kathy has been previously involved as the director of SAMHSA-funded Technical Assistance Center aimed at educating the aging network, mental health providers, and policymakers about behavioral health conditions among older adults. She's worked as a consultant on various aging and healthcare organizations, and she's been very much an advocate for older adults through many federally, privately funded projects. And as mentioned, she earned her degree in pharmacy and her master's of public health from Yale University. And the topic of her master's thesis, and I didn't know this, Kathy, was medication use and risk of falling amongst community-dwelling older adults. So as you can say, maybe as some of you studying with your master's, your thesis will go on to propel your work, right? Yes. So at this time, I'll let Amelia introduce the other panelist.
First, I would like to have a disclaimer. All of the other panelists are really great friends. So I'm going to not really read their bios, their long bios that someone once told me that some of these people have bios that could choke a giraffe. Laura Place is currently the coordinator of substance use intervention and treatment programs at the health center. And she has been a tireless advocate for college student health. And I just can't say enough about how inspiring she is to me. If I ever have a clinical question, I go to Laura. If one of my students has a question about what to do, I go to Laura. So she is providing a clinical perspective on the problem today, and she also wears another very important hat where she is the inspiration and I would say one of the founders of Terps for Recovery, which is our brand new collegiate recovery program here at the University of Maryland. And she received a master's in social work from the National Catholic School of Social Service in May 2011, and she is a Terp. She completed her undergrad degree here. Eric Wish and I go way back. I used to work for Eric at the beginning of my career here at Maryland, and he is the director of the Center for Substance Use Research here at the University of Maryland, College Park. He is a psychologist, but also a person who has a real appreciation for translating scientific evidence for people actually to use it. So he was the developer of the Caesar Fax, which was a great model for synthesizing information into pieces that people could understand. And most recently, he has a NIDA grant to establish the Coordinating Center for the National Drug Early Warning System, NDUS. Joan Webb Skornienchi is the executive director of HC Drug Free in Howard County. Joan is an incredible role model for women, for community-based advocates, for parents. If you need something done in a community, you go to Joan. She has received so many awards for her work in Howard County, and rightly so. She is just a mover and a shaker. That's all I can say. She is passionate about educating the next generation and saving lives, and her career spans more than 25 years in education, including extensive experience in higher education. And she has served as an alcohol and drug prevention specialist for a county-funded hospital program, and she holds a Bachelor of Science degree in Business Administration, a Master of Arts in Student Personnel Services, and she completed all but the dissertation for a doctorate in Education Administration. So really, we've got a very varied panel, and we would like to start out by asking each one of you the same question, which we have prepped you for, which is, what is the most important aspect of the problem from your lens? So Eric, we'll start with you. And we've asked each panelist to take about 5 minutes to answer that question.
Right. I want to thank you, Amelia, for inviting me to participate in this group. I feel like it's Old Home Week. I see a number of people in the audience who had worked at Caesar, and we have interns every year who come and work on our research projects, and we welcome you. And I had the pleasure of meeting your new dean, Dean Lishniak, about a week ago. Oh, there he is. And I know that your future is really bright with his leadership. Amelia mentioned that she's an epidemiologist, and I am a psychologist, but I was trained in psychiatric epidemiology, and I I think of my job as tracking the problem, defining the problem, and all these people, the rest of them on this panel, are the ones who have to decide what to do about it. And it's a much harder job, to be honest with you. Lunch a few months ago, and she mentioned her Widening the Lens article, which I urge everyone to read. Why we need to widen the lens about the opioid epidemic. And the same conclusion, and so I think that's how I ended up being on this panel. So let me tell you something. In the medicine, I did a postdoc with the leading drug researcher at the time, the late Lee Robbins, and she was asked by Dr. Jerome Jaffe and Dr. Robert DuPont, the first director of NIDA, to do this study to find out what was happening, what heroin everyone suspected when they came home. And she did this phenomenal follow-up study, She wrote a wonderful article about how the study changed our view of heroin. And I can't give you all the findings, you can find the article. But a major thing was, has such a bad reputation as a filtering down, a very small group. And these people, based on so all right, you could say that's Vietnam veterans. Well, we used to have surveys of adults and youth, and we would find if in a slew of every other drug. So again, we found the same thing. So the question is, has the prescription opioid epidemic changed the nature of who's using heroin? So first of all, I want to make it clear, and I think Amelia mentions this, only about 4 to 5% of the people who are using prescription opioids go on to heroin. It's a very small percentage, okay? Well, what we do in the NDOS project, and with another project we do for ONDCP, is we collect urine samples from a whole set of different populations, and we have them tested in a way that most other people can't. We have them tested for over 250 substances. So in this day and age, people don't know what they're taking. They don't know what drugs are being mixed in, and they don't know what the new drugs are that are being created. And so we have done loads of studies all over the country with people who've died, people who are coming into hospitals, who are coming into treatment programs, people in the criminal justice system. And what we find is that the people who test positive for fentanyl or heroin have a slew of other drugs in them at the same time. You know, everyone talks about fentanyl-related overdose deaths. When we studied them and found about an average of almost 4 drugs in every person who died of. So the issue is, I sort of think what Amelia was saying, we get off in our society drug and like opioids. It's all about opioids, when in fact a lot of other drugs. So what we need to do is widen the lens to look at who is it to addiction and to using these other drugs, and how to focus on the right now that we have a movement to from people who need them, when in fact it's a very small with them. With that, I just want to end by saying, if you're room, and please get on. We have a card there to get on, and basically what we're doing. I do want to say one thing. This is a great group. I don't know anything about using these drugs. I know about the people who are mainly the older people, if they're having trouble with these opioids. I don't know if our Thank
you, Eric.
Yep.
Joan?
Is this on? Can they hear me in the back? As loud as Eric. So thank you for inviting me here. I appreciate it. Here, and not knowing what today's topic is, what is the biggest issue? Our focus has been too narrow. So I think this is a wonderful topic. Zoom out and widen our view, and just kind of take a crisis. For many years was thought to be an inner city problem. Something that we can talk about. Talk about overdoses and drug use in many of our neighborhoods. Think about that drug use was happening, and stop and think about it happening in your child. So as we widen this lens, we work and we play, and we want to look at has changed the face of the opioid user, the opioid misuser, because it's us. It's everyone in this room. We could look at it and say, oh, that doesn't fit the opioid use today that we're seeing. At least that's what's going on in most of our communities. We need to include and look at the ripple effect, pain and devastation that's going on in our communities and in families. If we ended the opioid crisis right, the emotional devastation, the financial devastation, all the time and say, I've spent $250,000 or more. Children are still dying. So again, widen the lens. We need to look at mental health disorders, socioeconomic conditions, stigma. We need to look at all of that as we are looking at this topic. We need multi-sector collaboration to build comprehensive approaches. On the local level, many of us serve on coalitions and work groups, and we're trying to combine our resources and overcome the many needs facing our communities. And we need to keep trying to do that. I personally believe that prevention has come to mean preventing death. Naloxone and Narcan, so we can reverse overdoses and prevent death. Don't misunderstand. But because when there's life, there's hope. However, I'm an educator by training, and I'm working in the field of education to include everyone. So with the goal of keeping people from starting to use. You can't look into sweet, innocent faces of children and again, as a prevention person, it's about stop. That's our goal. So I want parents and teachers and the community all to do what we can to help kids. I say that death, and often say pre-birth to prepare the community for generations still to come. Because we deal with so many medications after families are cleaning out. Just a second to think about what a pill weighs. If I had an opioid in my hand, what does that weigh? When HC Drug Free does their twice boxes, so we collect throughout the year. But when we do our drive-through, we collected 1,212 pounds of medication. I mean, think about that, 1,212 pounds. Not just opioids, but a lot of them are opioids. And that's what we want to do. Of the community, I want it out of the bay, I want it properly disposed of. first of all, I want them to talk to their doctors, not to bring medication into their home. Store it. This is a sample of a box that we've been giving away. So store the medications that you have to keep in your need quickly and properly. Widen the lens in the community.
As a licensed clinical social worker and the resident clinician on the panel today, sort of riffing off of something that you just said, perspective is actually more about the experience. I just don't want them to die. That's actually a fairly, so I see really three things from the treatment and is that we have to keep people alive. Part of this is naloxone, but I agree with you. I don't already know what naloxone is. Oh, that's okay, all right. With people not raising their hand. So naloxone that emergency medical professionals would use opioid overdose. Sometimes it can take multiple doses, and it's with their combined effect of opioids and other substances. Miraculous. Someone can go from blue to green and moving forward. So one of the things that's actually happening at 8 o'clock was a training in the health center for students. Later, I brought some business cards. Let me know. But this, and that's important. Recovering from an overdose is just a chance to keep living. Dead, they can't recover, right? So the step after access to treatment, and for be accessible in a time frame that's actually relevant to the individual. Hours or days of the based, which unfortunately a lot of addiction treatment in our country, sort of assumptions and myth and old information. Evidence-based interventions primarily include things like cognitive, but even more than that, evidence-based treatment for addiction means that it is personalized. And even something that may be really important for a person's recovery, it may not be the thing that carries them through the next, hopefully, life. And then the piece after that, it doesn't really just stop with communities. I don't want to assume, I never want to assume that I'm people in the room, I'm just going to take the guess that there's someone in here who's experiencing, who's fantastic, but it's really scary to be the one person. Instead, we've seen some remarkable things happen and advocate for themselves. So you can see this in the, and I also get to see it playing out on the recovery community here at Maryland. The more time that students in recovery, the less motivated and empowered they are to speak out about the not only on campus and in our community. And I think that this stigma who are either in recovery or people who love and respect and understand feedback effect, because if we don't fight that stigma by coming together as are not effective at getting our jurisdictions and all of the decision makers strategies that help to keep people alive and get them access to treatment.
Kim?
Everyone, it's really wonderful to be here. Thank you for the invitation. Council on Aging, we're based in Arlington, has the right to age well, and that includes those who are suffering from chronic opioid epidemic. To answer the question that was posed to us, we really believe that balancing the need for abuse and addiction is really the most important. We really take a preventive, proactive approach to dealing with this issue. We don't want to go back to the days where pain was undertreated significantly, particularly among older adults. Older adults tend to be stoic and don't report that they have pain, and therefore, for decades, pain was undertreated in this population, still is today, and we certainly don't want to go back to that period of time. But about 80% of older adults suffer from a chronic condition that creates pain in one way or another. And I think Nikki really provided a good framework for what we know about pain in older adults because of conditions like osteoarthritis, chronic back pain, injuries that they may have sustained from a fall or surgery or cancer. And pain really impacts the daily living of older adults significantly. One area of work that we're focusing more and more on is social isolation. And we know that people who are in chronic pain have higher rates of social isolation, decrease in social connectedness, and more research is showing that social connectedness is related to health outcomes and longevity. So we want to make sure that we treat pain effectively while, again, reducing the burden of opioid addiction. And we know that medications should be a part of a treatment plan for older adults and anyone suffering from chronic pain. But we need to look at other therapies too, and that's something that we're focusing more and more on at the National Council on Aging. And this includes alternative methods that encourage older adults to take a much more proactive role in their pain, such as self-management programs that I'll talk about in a moment. But it also includes some of the things already mentioned: cognitive behavioral therapy, rehab, physical therapy, guided imagery, massage therapy. So the step therapy approach really helps people in chronic pain to figure out, what's the best approach to managing their pain, and then kind of working with different approaches over the long term. And it's really a person-centered approach with goal setting for pain management. There's even more and more research showing that programs like Tai Chi is important for reducing pain, particularly some of the neurologic pain. And in fact, the VA is using Tai Chi for reducing pain among veterans. It's using Tai Chi for PTSD and to reduce opioid use. Nikki mentioned that some of the work we do is around evidence-based programs, and there are a number of community-based, evidence-based programs that we help to promote and get community-based organizations to implement across the country. And one of these programs that we promote is the Chronic Pain Self-Management Program, and it's part of a whole suite of self-management programs that were developed at Stanford University School of Medicine. In addition to chronic pain, there's one for diabetes, general chronic conditions, one for HIV, and one for cancer survivors. And these are programs, the chronic pain program in particular has been shown to reduce significantly symptoms of pain. It improves satisfaction with life, self-efficacy, and it's a program that's available for small groups in community settings. It could be places like senior centers, area agencies on aging, other types of community centers, hospitals, health departments, and so on. And it brings people together who have experienced the same type of conditions, in this case, chronic pain. And it's a 6-week program, 2.5 hours per week. And during the program, participants learn techniques to manage ongoing pain, frustration that they might be feeling, fatigue that they experience with pain, isolation that I talked about. They learned sleep hygiene habits. But I think the secret ingredient of these programs is that the participants learn from each other. So it's kind of a peer support group. So they learn strategies from one another. And the program is led by trained coaches, and one of those coaches has to be someone who's gone through the program before, who has experience with chronic pain and can really talk from the heart about what's worked for them. In Maryland, this program is being offered through the Living Well Center of Excellence. It's based at an area agency on aging in Salisbury, Maryland. And they're working with pain centers, they're working with older adult community centers, residential care, and they're working with homeless veterans in Baltimore to offer this program to them to manage their pain. So it's something to consider in the whole array of services and programs to meet the needs of people with chronic pain. It's currently being studied right now through a PCORI grant to look at its impact on reducing the use of opioids among people with chronic pain. So the data is still out on that. We have about a year to go before that data will be available. So I wanted to mention that program. Another program that we help to promote is screening, brief intervention, and referral to treatment. And maybe some of you are familiar with this program, but it really takes an approach at early intervention to identify people who are at risk for substance misuse. Across all, screening kind of quickly assesses the level of treatment that's needed. Then the brief the use of motivational interviewing and goal. Need referral to treatment, it can be made through this intervention. So in primary care offices, but others can be treated across a variety of different settings across the country, again, to intervene early and identify people who have been shown to be very effective in the older adult population. So examples as ways that we can for substance misuse and hopefully prevent some of
education to the public, to the professionals about all kinds of issues of aging and behavioral health, and being asked what the most important aspect is, I really have to say it's stigma. And it's stigma in two ways. It's stigma of substance use disorders or abuse or addiction, especially among a population where it was really not okay for ladies to drink or get drunk, back in the 30s and 40s and 50s when some of these folks were growing up. And so to them, the person with a drug problem or alcohol problem is somebody that they don't really relate to when they're an older adult. The stigma of aging is the other stigma. It's a double stigma. Stigma of drugs and alcohol, stigma of aging. And a lot of older adults fly under the radar because we are not recognizing them as having a problem with drugs and alcohol. And when it comes to opiates, they are in the low consumption group, but we're not flagging them because a lot of the criteria that we use to determine if somebody has a problem doesn't really apply to an older adult. They are retired, so they're not missing school. They're not missing work, the kinds of things that we would look for in others. The other thing is that they're not usually seeking to get high. They are trying to do the things that they want to do through enormous pain. So pain's been brought up. Nobody wants to deal with pain. As an older grandparent wanting to just be able to go to the mall with a grandchild or take them to the park and walk around. And these are the kinds of things that accidentally bring them into this world of pain that they still probably don't even identify. And the consequences that they suffer of the use of these drugs, they may attribute those consequences to other aging things. So if they're particularly tired, it's because I'm old, you know, and so my stomach hurts because I'm old. And we're not pulling apart the things that we need to for this very unique population. The urgency is in the growing number of older adults. So as a population, they're expanding, but I talked a little bit in the beginning about people having that stigma of it's not okay to do drugs and alcohol. Well, so our new older adults are our Woodstock people who were like, yeah, I can do this. And maybe they've put it on hold for a while, and maybe they're coming back to it. And I tell people all the time, if you imagine the Rolling Stones, they're in their 70s. Imagine having them in your nursing home. I mean, that's really a problem. So we have a lot of education to do. We need to educate older adults, people who have never had a drug or alcohol problem. We need to educate them about their vulnerabilities as they get older. They need to understand that their metabolism is different, and just by virtue of that, drugs and alcohol are going to affect them differently. We have to have their family members and caregivers know this. People who are working in healthcare, obviously, but also people working in social services, in places where older adults are. So I've been doing more education in senior centers and in housing where we've got a lot of older adults aging in place, and the people in the buildings need to be able to identify these problems and to be able to have these very sensitive conversations with older adults. We've got some literature that suggests that even primary care physicians feel really uncomfortable talking to older adults about issues of addiction. Primary care physicians and people in healthcare in general might be really reluctant to prescribe some of these medications. So this is something that requires conversations that we just typically haven't had in the past. We need to infuse geriatric education so that people understand aging issues. But there's two other things that I want to say real quick. Older adults are also victims by the drug use and abuse and addiction issues of their kids, because increasingly they are supporting their adult children who have addiction issues. And this is huge. They are parenting their grandchildren. So they've got a lot of secondary issues. And then I want to add another approach to this, because I'm a person in recovery. And I think all the time about when I'm in a nursing home or when I'm in assisted living, where am I going to get my support? And we need to be expanding the support. Older adults typically, if they come into recovery at the age of 70 and they go to a Narcotics Anonymous meeting, it ain't gonna last very long. They do not relate to the younger people talking about the drugs and the reason they did the drugs that they do. They have a whole other set of issues, and so we need to tailor some of these things to older adults in terms of prevention, intervention, treatment, and recovery. And we need to realize that a lot of older people who've been in recovery long term, so I have a very close friend, she's 92. She's been in recovery for 40 years. And when she fell down and broke her leg and went to the hospital, she didn't want to tell anybody her history of addiction. And so they prescribed her OxyContin, I think it was. They gave her 90 tablets. 90 tablets, maybe because she's an old lady, she's not going to get addicted now. And so she was scared to death to take them, and she didn't tell anybody. So there's so many levels. But these are things that we need to think about that our culture hasn't had to think about before.
Great. Well, I think you can see how great the panel is in terms of their variety of perspectives. And now we want to give the audience a chance to ask a question or two. Nicole, do you want to sort of moderate those questions?
Absolutely. Well, do you want me to be the roaming mic, Amelia?
all you have to do is point.
Okay.
And someone will go to the person. So you get to pick.
Like over here, this gentleman in the front.
Hi.
Great.
Kim, before you had mentioned, John McElligott, I'm with the PHS Commission Officers Foundation. Before you had mentioned stigma, I think I heard every other panelist mention stigma. So it's pretty common. I'm wondering in my head, trying to create a Venn diagram of if the stigma is across all the generations, okay? And if that's true, of the people at risk, how many of those people have access to care and are more likely to seek help? Then I'm also wondering, to fight the stigma, I recall when HIV blew up in the US, Magic Johnson eventually came out and said I was positive. Does the country need a Magic Johnson-like popular figure in each generation to speak to that generation, or what approaches would work? Thanks.
I think you said Kim, but I am not the person to answer those questions. Does anybody else want to take a swipe?
I mean, I can take a stab. I'd say that from what I understand, treatment-seeking rates for substance use disorders across all populations is quite low. And this is not the only marker for stigma, but it's one that suggests to me that, you know, this is present across all populations. And there are, fortunately, I think the idea of having celebrities who are in recovery and who are honest about their recovery and open about that, I think that can be very powerful, and we do have some of those examples, like John McElmore. And I'm assuming that there are other people as well, but I'm actually pretty bad at naming celebrities, period. Unless they're Star Trek actors, I can't help you there. But I think that is part of it, but it's not just powerful or famous people speaking out about recovery. I think there's a lot of power for people who are part of a community speaking out and saying, I'm in recovery and I'm part of this community. Because someone else, you were mentioning this in terms of the importance of treatment being relatable. Prevention and connection has to be relatable too. If you're a student in a classroom with someone and they speak out and they say, well, oh, I'm in recovery, that makes them, and I hear this from the students that I work with who are in recovery, that makes them an approachable person to talk to about your problems, about addiction treatment, about recovery.
And I think, Laura, you hit on a really great point. I think both Kathy and Joan brought it up. Joan in Howard County with your work, Kathy with the senior centers and peer-to-peer and that support. So I think, garnering that within the community, but also recognizing the different demographics and the needs are going to vary. Eric, I don't know if you want to build on that from your perspective as well, just from your years of research and practice. Anything else to add to that? No? Okay.
This isn't totally on the topic, but I'm oftentimes not on it. Almost everything we know about addiction from epidemiologic studies suggests that the people who get into trouble start young, and that's where our prevention should be focused. We do not know whether the people who get into trouble have some type of neurological setup that makes them more at risk for that, or if it's a combination of that and some environmental and learning issues. But we really need to start real early at understanding who is at risk, because it's a small group of people who are really at risk for having troubles with these drugs. And we're not really good at the moment of determining who they are in advance. And think about it, if all of these physicians who are giving out the pain medications could do a better job of knowing this small group of my patients are really at risk of having problems, and therefore I have to do some additional things with them. We really aren't at that level yet.
I'd like to add to that. When I ask young people, teenagers, how can I better get this message out? Who would you listen to? They're quick to say, yes, that recognizable, famous person that teenagers would know. But yet, when they expand on that, if you just let them keep talking, they always get back to, it would mean as much, if not more, to have somebody closer to their age that they can relate to. For example, I have a young guy, not quite their age anymore, but he graduated from one of our high schools. He was the homecoming king. You know, he had that classic story of all the right things, great athlete, championship rings in 2 sports in college, got the college degree, did all of that. Long story short, blew out his knees. Got addicted to opioids, did not know he was addicted until he went into withdrawal when he couldn't get them anymore. Again, play that forward, ended up incarcerated. Now he's back working with us. These kids can really relate because he went to one of their high schools. He did all these things right. So my overachievers sitting there who are trying to build better resumes than I'll ever have are looking at him saying, he graduated, he did all the right things, he went to college, he did all the right things, and he still ended up incarcerated. So I think that's more powerful. And if you ask the kids, like, who would you trust? It still gets back to just trusting the information. And I know that's why kids come back to our Teen Advisory Council every month. And I ask them, like, why? I know I'm not that exciting. I know the pizza's not that great. Why do you come back year after year? Why, like, after an older sibling, does the next one come along? And the answer is because they trust the information. They know we're not going to lie. We're not going to tell them everything's going to kill them. It's not. So I think it's that trust issue. The other thing, and I want to piggyback on what Eric said, is when I do focus groups across the county, one thing that I keep hearing from people in recovery or still actively using, so for the most part, young people. So I've already been in and out of recovery in the early 20s. And what they tell me again and again is that it was the first pill. The first opioid had them. And that's their words, had them. Something changed with that first pill. Now think how frightening that is for parents when I have to say to them, you're taking your kids to the best sports injury doctor who might prescribe opioids. Okay, they've done everything right, the best money can buy. They're taking them to the best dental surgeons for wisdom teeth. Until their kid takes those pills, what's going to happen? You don't realize till years later that's what triggered it. So again, and delay opioid exposure. How many times the kids will say to me that now, finally, the parents aren't filling those prescriptions more than something over the counter, and many times they would have come home, they would have been told, get ahead of the pain, take the opioid, and they would have just get 7 or 9, but that's too many if it's the first one.
Question from the audience?
Yep,
Just let's ask another question from the
question.
Hi.
Yes.
So you talked briefly about alternatives, a little bit about marijuana use and how just reading or heard on the radio recently, I'm sorry, I'm not citing my source, either medical marijuana access, or have seen a decrease in opioid use. And I'm wondering your
handle that question. It's really that's level, because I think that one study, and one of the explanations that's most plausible for that, probably more progressive to begin with, like they had prescription drug monitoring programs before. We have to be super careful not to make marijuana availability and the solution to the opioid crisis, and really look at the individual level data, the prospective studies that have shown actually that marijuana can increase the likelihood that someone will start to use prescription opioids, non-medically.
I think there's been a lot of research kind of looking at marijuana. I think that the jury for sure is still out. Some of the research has shown that people who use marijuana can decrease their opioid use. They have better sleep, better function during the day. But I agree, there needs to be certainly more research looking at this question and the impact that marijuana has on particular groups of people with chronic pain.
There was a question in the back of the room. The microphone's coming back.
Thank you. I just wanted to run a particular scenario by you, and I think earlier on you kind of brushed over it a little bit. In the instance where opioids are prescribed, they may be needed, however, but the scenario you gave where there were like 90 pills, I do know of a situation where a large number of pills were prescribed. And my question to the physician was, why are you prescribing so many of these pills? And his response was that the insurance companies would not approve the smaller amount because of the way these things are packaged. But the problem is that it lends itself to other problems, which is that if you have somebody that's out of work on workers' comp because they had an injury, they get, say for instance, they get 300 pills when all they needed was a month's supply. Well, somebody who is trying to run a pill mill or something, they can say, well, hey, let me get, you hold your 30 pills, I'll give you $5 a pill for the other 270. Then that person ends up into a situation that is actually criminal activity. But insurance companies have, I guess, opened the door for some of these types of scenarios to take place, as is the fact that if you have these many pills in your medicine cabinet, you have kids or other people around who go by and actually see them, then you have another situation. So it's actually a sense of being more responsible with what you have. If you don't need it, question the doctor. You know your body better than your physician does. So just wanted to kind of get your feedback on that.
Sure, I'll take the first step at that one. I think it's a really great question. What we've seen in terms of prescribing practices, I think we have to take a step back. You know, what is the indication for use? A lot of work's being brought to attention on why are we starting to prescribe an opioid or something else for that pain management. Is this acute pain versus chronic pain? So step number one, you know, and I think we're starting to change prescribing behaviors by asking that very simple question. So if it's acute pain, you're absolutely right. Justifying 30 days, 90 pills in a vial is something we have to really question. Chronic pain, I think we still have to look at quantity limits and what we're giving access to. There's been some propagating poor prescribing through the years, through some of these, as you call them, pain mills or pain clinics sometimes, and giving multiple months of supplies of medications because of the reimbursement structure that might be in place. It's not an adequate justification. I think what we're seeing come down, and you may be aware, is as the insurances are looking at how we can curb access and curb diversion, as another way, is what you're hitting at, is we're curbing quantity limits. But I think there's got to be a place there of justification for depending on what those patients' needs are. Because my concern is, and I'll say as I'm reading some of the requirements that are coming down the pipe, not everybody is 7-day quantity limit adequate. I think of our patients trying to get their providers after 1 week, and the feasibility and the burden it puts on that family and that support system to get them to a doctor after just 5 days to make sure they don't run out of medication. So I think there is a balance when we talk about access, and I think quantity limits is one of the ways we could look at that. But you're spot on. I think we need to look at what's the indication, is this the safest medication, and not just make a blanket statement for all. But I think as was mentioned by Joan, almost over 1,000 pounds of agent of medications, narcotics being out there just in one county is just appalling, and how we dispose of them and the environmental hazards. So I think you bring up a really great point. But I think as we make public policy, we need to be cognizant of some of the individual needs of some of our patients too. So I do worry a little bit on where we're going. So, but yes, something needs to be done. And I think, just again, from a you know, an access perspective and a diversion perspective, you know, I've seen, you know, just the abuse I think Kim alluded to in some of our cases, and I think all of us within the public realm need to be very cognizant of sometimes our older adults are maybe getting medications to give to their younger adults, and they may be getting abused because of that. So I think there's a whole nother societal aspect we need to look at, and I've run into a couple of cases that as well. But you're absolutely right. Access, numbers, quantity, safety is a paramount issue, so thank you for that. I think there was a gentleman right over here, though, with a question.
So from panelists focusing on younger individuals who are addicted, I'm hearing that the first pill is the most dangerous one, and we need to focus on prevention. But then the panelists talked about older individuals. I hear that pain is undertreated, and then further, there's a stigma for those who are taking these pills against seeking treatment because they don't want to admit that they are taking the pills. And the only solution I can see is prescribing each pill with the assumption that it could result in addiction. Because we can't just do prevention, otherwise we have undertreatment. And we can't just prescribe willy-nilly because then people aren't seeking treatment. So what's stopping us from prescribing pills on a guilty until proven innocent basis that, you know, comes packaged with addiction treatment?
I have a thought. So you had mentioned, a couple of people had mentioned screening, brief intervention, and referral to treatment. I think that that actually kind of slots in fairly tidily into the problem that you lay out, because it is reality. We don't know. Is this the pill that we're going, you know, not that I prescribe things, but is this the pill that someone is going to be prescribed, and this is the thing that they're going to develop an addiction to, or this is the thing that's going to enhance a currently existing problem with substance use? But if we made regular brief screening, assessment, and if necessary referral to treatment part of everybody's primary care in the medical environment, although that first pill may be enough to know, oh yeah, this has got me, this is something that I really have a hard time turning down, we also know that the earlier someone starts engaging with treatments or supports, the less they need to recover, and the more likely they are to recover and do so quickly. So I think that's really the piece too. It's not, all of these pieces are important, right? And one of the things that I heard as a theme of your sort of dilemma here is that it also depends on the specific population. So providers who are working within specific populations need to, and possibly with multiple populations, need to understand the different elements at play with them. And physicians, by and large, are not very comfortable answering these questions. This is not something, like, can I ask, how many of you were asked more than 1 or 2 questions at your last medical visit about your substance use? So that's right. So this is the problem. If we were asking these questions, if it was a routine part of medical care, then we'd be able to catch these problems sooner. There's a myth that people won't tell their doctors the truth, and while this is true in some cases, a lot of people will just go ahead and tell their doctor the truth if their doctor asks in a concrete, clear, non-judgmental way, which they can do with a form. You don't even have to worry about what your face looks like when you're asking the question if you've asked it on a piece of paper and the question was framed correctly.
Great point. Other questions? We have a question back here. Okay, I'll try to repeat. So I know the microphone's a little poor.
It's working.
And I was just curious on your thoughts on genetic and opioid risk. I know that we have studies done on alcoholism in identical twins.
So I think the question, I just want to make sure I get that completely. So it sounds like identifying some of the risk factors and what has been done from genetic testing to kind of other types of angles for that. I don't know if someone wants to speak to that first. Amelia?
Just really quickly, because that's a really central, important, but complex question. So we know that addiction is preceded by a number of genetic and environmental influences, so it's hard to get away from both. But the cardinal feature of that genetic predisposition appears to be dysregulation in two major areas. One is behavioral dysregulation, where someone just can't regulate their activities. People who sort of like ADHD, but a little bit more dysregulated behaviorally. And the other is emotional dysregulation, where they can't really control their emotions as well. And then the other half of it is internalizing symptoms, like not being able to regulate their mood. Maybe they're sad all the time. So on the other side, sort of the depression. But it's not necessarily like inheriting a gene for addiction. It's sort of inheriting genes, multiple genes, that play into this dysregulation of behavior and emotion. I hope that answers your question partially. But people have written books about that question.
Really good question. Any other questions from the audience? Up here? Great. And we were afraid there wasn't going to be any questions, right? This is great. Thank you.
Hi. So I had a question about the stigma around drug use, and I know you mentioned how doctors with health assessments can ask their patients, do you have issues with substance abuse? However the question is worded. But in my home state in Tennessee, if a pregnant mom admits that she has been using drugs, she's criminalized and she can be put in jail for a long time, and her infant can be taken away from her because there is a, I can't think of the name of it right now, but babies are born being addicted to opiates. I can't think of the term. But what are your thoughts on the different policies that Maryland has? Because I'm not as familiar with this state. I haven't been here that long. But when it comes to criminalizing people who are seeking help or admitting to something that may have some type of criminal repercussions.
So, in general, that's a terrible policy, because there's plenty of evidence that shows that criminalizing, especially criminalizing the initial steps toward treatment seeking, to be clear, I am speaking from my own personal views and not some health center view, but I understand that there was some legislation proposed in Maryland to basically criminalize overdose, so that if you were to receive, there's some legislators who would prefer that people who receive life-saving treatment for opioid overdose, if they do not then proceed to get treatment and have additional overdoses, that they would somehow be criminally liable for not recovering fast enough. That's a problem, right? Because it holds people back. There are enough barriers to treatment without adding any. Like, that's a problem we don't need to solve. I think I got so mad for a second there that I just forgot about the rest of the things I was gonna say. I don't think that Maryland, I mean, that's just proposed legislation, and Maryland, I think, is a little too liberal for that to really go through. Fingers crossed, but you know, fight what you have to fight. But there isn't, I certainly don't have to deal with situations like that. So I know there is not a law like that in Maryland. I am able to treat students, even students on a college campus, which is governed not only by HIPAA but by FERPA. I am able to treat students with confidentiality in almost all circumstances, even if they report that they're using drugs really heavily. In our state, you know, for better and for worse, you also can, although you can emergency petition someone to go to the hospital because they're intending to commit suicide quickly, like tomorrow, if I have a student in my office say, you know, I'm really just hoping that eventually one of these times I use is going to be the last time I do anything. That sort of passive suicidality and intensive drug use, I can't make someone get treatment they don't want, which is mostly good and also bears some costs. Does that answer your question?
I think there's one more comment from a panelist.
Yeah, I'm going to hit it from a little bit of a different perspective. For many years, I've been doing research where I compare what people report, even in research interviews, versus what we find when we test their urine specimens. And we have always found a lot fewer drugs. We find a lot more drugs in the urine than people report. And it used to be because people didn't want to admit in these different settings to their using drugs recently. Now, the whole nature of drugs have changed so much with the new psychoactive substances. People don't know what they're taking. So your physician, in order to really be able to understand what they're treating, need to do some type of biologic testing so they can say, all right, you've taken fentanyl, you've taken other things. It's so hard to diagnose this now that's really necessary. Now, once you do the testing and you find all these drugs, then you come up to your question about what do you do with it, and is there a legal issue here? And I would agree with everything that's been said. It should be looked at in a health way and promoting health, not in terms of prosecuting anyone. But it's really necessary in this day and age. We've done studies of people coming into hospital ED departments where the doctors thought they were using certain drugs, and we find a whole different set of drugs that they didn't even know about. So in this day and age, you have to go beyond asking people, and you have to do the testing, but it has to be protected.
Those are some great points from a policy perspective. I want to make sure we give the panelists a couple moments as we're wrapping up. I can't believe how this time has flown by. So I'm going to start, Kim, with you. Any kind of closing remarks, any perspectives based on the conversation today you want the audience to take away that we didn't ask about?
I think what I would like to say, seeing a lot of young faces out there, is go into this. Go into this field. We need you, and there's going to be a ton of opportunity.
Thanks. Kathy?
Great. Yes, I would definitely agree with that, and please go into geriatrics. We don't have enough professionals in the field, and as we've talked about, certainly a huge and growing population. I'm hopeful. I think that the epidemic among older adults with opioids and other substances used to be called the silent epidemic. That's changing. I think it's becoming much more open, and people are talking about it a lot more. So I'm hopeful that we will get them, more older adults, into treatment so that they can live the lives that they want to live in their older years. I'm hopeful, too, there are efforts going on at the federal government with federal agencies to come together to address this issue among older adults, where that hasn't happened before. So I think over the next few years we're going to see a lot more activity to address this problem among older adults.
I think the main thing that jumps out at me that I want really everyone to know is to not get suckered by the media narrative that says that everyone who gets addiction is going to lead a miserable life and die of overdose. Recovery is not only possible, it is probable, and with the right supports, it is incredibly achievable. So that's the main thing that I want people to be aware of. Also, whether it's you or someone that you know, there are evidence-based strategies for everyone involved at all levels of this problem, whether it's you as an individual or someone in your family. So don't accept this narrative that you're just stuck, or you're someone you care about is just stuck, or your community is just stuck with this. There are things that you can do.
I agree with that, that there is a lot of hope. There are many things that you can do. And if you're sitting there and you're a little nervous, or you're thinking about your children or having children someday, then my advice to you is take care of yourself first. Make sure that you don't have a problem, develop a problem, and then take care of the loved ones around you, and then expand that circle. Because you really can't take care of your children and be the best parent if you are in the midst of addiction. And again, but recovery absolutely does work. And I will say too that, especially because we have people here on a college campus, don't trust your local drug dealer. Don't take pills that just because the pill looks like what you think it is. There are so many really good fake pills right now that if we had two of them right here, you couldn't tell the difference. The safest thing, again, speaking from prevention and education, is to not use, not worry about what's the safest of your options. It's simply to not do it.
Eric?
Yeah, I have this quote I want to read to you that sort of summarizes the position that I've been trying to espouse today. It would seem that our society has overemphasized the importance of treatment for heroin per se, failing to pay attention to the multiple other problems that heroin addicts have. Heroin addicts are deeply involved with a great variety of other drugs at the same time they are involved with heroin, and they have all kinds of social adjustment difficulties that are not entirely attributable to heroin. It is a small wonder that our treatment results have not been more impressive when they are focused so narrowly on only one part of the problem. That was written by Dr. Lee Robbins, the head of that Vietnam study I talked about, and it's as appropriate today as it was then. It is not just an opioid problem. It is a much bigger problem to the extent that we focus on, we'll just give them this medicine to focus on their opioids. We're not going to do as well if we don't realize generally the history of other drug use that accompany the heroin and the fentanyl use.
I would just like to thank everybody for coming and spreading the word about the importance of taking a broad public health perspective to handle not only this issue, but a lot of the issues that were discussed all day today. So thank you very much, Nicole.
Yeah, and I just want to echo that. I think it's important as we're standing up here as a University of Maryland system and beyond. There's a lot of resources in our communities. There's a lot of resources on our state, and there's a lot more work to be done. So I love the title. Hopefully this captured what we were trying to get across. And again, we hope if you have more questions for us, we'll stay up afterwards. But thank you for your time and your energy with this effort. So thank you.
I'd like to also add that I have 2 medication storage boxes that I do not need to take back home with me. So here's one, and the box for it is over here, and there's another one right on my bag. So first people to get them, take them.
Together.
Thank you. It was a pleasure.
Okay. Fantastic. Okay.
What are we doing?
Okay. Do you want to go around? Okay.
So one moment, please. We are now moving to our closing remarks in this room, and then we'll be having a brief reception after. So closing remarks now, and then a reception. Thank you.
Okay, we're going to wrap it up for those that are still here. Okay, I want to, my remarks are going to be very brief. I think that our theme about reimagining is very, very important and valuable. I think we heard a lot of, the keynote talk was extremely energized and thoughtful. I think the 4 panels that we had, I only heard 2 of them because I couldn't be in 2 places at one time. I haven't conquered that challenge yet, but I'm sure somebody will someday. But for now, I think that they raised a lot of very interesting questions. I thought the posters were absolutely outstanding and far beyond what I would have imagined could be done by our students at all levels. I mean, the posters that I saw for the undergraduates, the master's, and the doctoral level were all really very, very provocative, very interesting, and represented a very wide range of experience, both within the university system walls, both in Baltimore and here in College Park, but also outside. They had a tremendous outreach to the community, which I also thought was extremely valuable. I also just want to thank everybody, and I'm glad that we were able to see such valuable and useful collaboration and cooperation in bringing about today's program.
Great, thank you, Jay. So it seems like we started this like sometime this morning, although I'm kind of in this daze yet. I'm in this daze because of the success of the day. In fact, the success of the several days that we've had here celebrating a 10th anniversary and closing that celebration, here with many and all of our partners here within the University of Maryland, Baltimore, within the University of Maryland, College Park. And looking at the success. So, you know, if you felt good vibes today, right, it really is an extraordinary feeling. You want to feel those vibes and feel like you can bottle them and bring them out occasionally. Highlights. You know, Jay talked about what we saw today, right? Reflect on the fact, those of you who were blessed to be here all day, and I realize it's the end of the day. All of us really want to go home, but I appreciate you being here, and afterwards we'll have a reception in the back. You can mill. But highlights for me was, you know, as always, the opening ceremonies, where we have the leadership of our institutions here. And many of them are rather busy, and sometimes they float in and go on to other things. But it's important that we have that connectivity with leadership, and we'll be having words from another one of our leaders here at the University of Maryland in College Park shortly. The Besser talk, I thought Rich did an outstanding job, but it was mostly looking at the room, actually, that was filled not only here, but into our overflow room. That, ladies and gentlemen, is progress, right? It's progress for the success of this meeting. It's progress for having instilled an interest in this theme. Walking through the poster sessions today, there was a magic in the air. It could be that I've not had enough sleep recently, but there was something there that was very palpable. We talked in smaller groups amongst faculty and many of our partners that the quality of the posters, the type of presentations there, was probably the highest we've seen in these 6 years. The ability to honor our undergraduate, graduate students, doctoral students, all levels, to be able to engage them, to see the pride in their eyes as you would come up and question them. We sometimes forget that for the students, this is a big event, right? To stand in front of your work, to put those words together on a sheet of large paper, and then to have that anticipation of someone coming by being interested in your work, What we did this afternoon, like we've done 5 years before and this in our 6th year, is immeasurable in terms of the impact on that student who now walks away proud, right? There's phone calls right now to parents saying, oh my God, I did my first poster, or perhaps my second poster, right? We who have been around for a while forget that what took place is important. And it's important for the rest of their scientific careers, for the rest of their public health action careers. There's many people to thank here, and you know, I'm not going to go into names, right? Because we'll forget somebody, and it's not about names. You know who you are, right? The team of staff, the students and faculty, the planning, logistics, poster judging, the panel session groups and co-moderators. You'll get our email, which is just an electronic message. You can print it out. You've gotten some fancy label on your name tag that says you played a role here, a color coding. But we walk away with more than that. And I hope you are invigorated and reinvigorated with the theme of today, with our attempt to look at reimagining health. It's only an attempt. We don't solve the world's problems here. We rededicate faculty and staff to our mission. For students, my hope is you are more interested than ever in this beautiful and glorious field of public health. This is an uplifting experience for us all. So thank you for what you have brought to this meeting. Thank you for making it a success. And now to conclude our meeting, this is kind of like, you know, the person who ultimately presses the button and the Olympic flame goes out. I, as one of the co-leads of health, will say a line I used at the Gold Innovation Awards is that, you know, I call upon the youth of the world to gather 1 year hence, and they look. It doesn't end on just, it's over. It ends with a call saying, we will gather yet again. So begin the training, begin the preparation, begin the hard work. We have outstanding expectations from a year from now. Dr. Lori Locascio, who's relatively new to our 5 months in. So I'm a year and 2 months in, so I'm the veteran. Jay, how long have you been at the University of Maryland now? A little bit longer.
35, 36.
36.
Years.
Years, yeah. So we changed the parameter. The graph changes. You have to look at the, but anyhow, Lori comes to us from federal service, comes to us with a stellar career involved in research, National Institute for Standards and Technology, and now serves as the Vice President for Research here at the University of Maryland, College Park. Ladies and gentlemen, as I've said multiple times today, give it up for Dr. Lori Locascio.
I have got to tell you, when I came here from federal government, after being in the federal government for decades, I said, you know, I want to go to a university because I want to go back to school and I want to take some classes and I want to learn and maybe I'll get another degree. I do have a PhD, but now I know exactly what I want to major in. So if my professors are out there, look for me in your classes. Thanks for inviting me here today. Yeah, I have been here for 5 months, but so many exciting things to do and to see here, and I'm really happy that I was able to attend the last session here today. It was such a powerful and motivating panel here, listening to them talk about addiction and the future of how we can solve that, hopefully, for the United States and for Maryland. But I'm pleased to join you here in my first year at the University of Maryland for the 6th annual Public Health Research at Maryland event. And of course, it started last night for me when I was invited to attend the celebratory dinner. Kicked off with that celebration where I got to sit beside Dr. Richard Besser, and hear about his adventures and how he came in from CDC through ABC News all the way to where he is today as CEO of Robert Wood Johnson Foundation. And just that story, and also hearing the stories about your trajectory as well from him, were really fun.
They were all lies.
They weren't lies. He verified, showed data. But it's an exciting day, and it's all dedicated, of course, to the celebration of research across this university. And our partnership, our very strong partnership with the University of Maryland, Baltimore, and the University System of Maryland, along with community partners and government agencies, and many of them were around today. Our proximity, as a federal government employee for many years, one of the things that I got involved in was policy making downtown. And being so close to the nation's capital comes with amazing responsibility, but also opportunity. It's really the opportunity for us to stand up and show how things can be done. And in this case, we can show the nation what can be done to address these critical public health issues that everyone is struggling with. And we have such a good relationship with the federal government being so close by. Our voice can really be impactful and heard. This signature Empowering the State event that started today and early this morning highlights public health research and showcases really such a diversity of disciplines that are needed to address these major health challenges that we are dealing with in Maryland and in the country and in the world. And there are so many exciting and transformative projects between the University of Maryland campuses at College Park and Baltimore that include transdisciplinary research on aging that you've heard about, and projects like Cole's Center for Sports Medicine, Health and Human Performance, Conserve, and Catch the Virus. All of these together elevate our collective standing of our institutions, and they offer these tremendous collaborative opportunities across our campuses and beyond. And I know many people were traveling down from Baltimore today to participate here, and it is truly a joint effort. We're fortunate to be able to leverage expertise and diversity of thought between our campuses, and this ultimately makes major contributions to the health and well-being of our citizens. As was brought up today, of course, we had these poster sessions that went on all day, and I heard the statistic that nearly 90% of the research posters were presented by students at the undergraduate, master's, and doctoral level. This impressive statistic is really a reflection of how important students, their role is to research. And it's also a reflection of our commitment to research mentorship and research training, and also the quality of the students that we're able to attract into our programs. And I'm sure you were able to see that today. And then beyond our walls, we collaborate and have formed very fruitful research collaborations with many agencies, the CDC, FDA, NIH, and of course, numerous private research institutions. So we look forward to what the students do in the future here and beyond. We look forward to continuing these very close relationships with all of the other agencies out there and private research institutions. And of course, we look forward to continuing this very, very strong partnership with the University of Maryland, Baltimore, and the University of Maryland, College Park. And so, as you said, we end with a charge. And so my charge to you today is to harness today's energy around reinventing and reimagining health and maximize that momentum to create the change that we need for a healthier nation. And so with that, I'd like to, of course, thank Boris Lushniak and Jay Magaziner for their leadership for this annual event today. It really reflects just the energy that we have at the University of Maryland behind this amazing strategic partnership. So thank you.
Hey everyone, let's gather, grab some food, mill, and talk, and when it's time to leave, safe travels home. Be careful out there.